I would like to thank first Elita and ELTA for providing the result, because I will also use data I get in the past from ELTA. And I would like also to thank very much the Scientific Committee of ESOT for this contribution, for allowing me to contribute to the session today. So I will concentrate on pediatric liver transplantation and start with just the limitation of this type of studies. And you already understood from the previous speaker that we have some limitation. The first is, what is long term? 5 years, 10 years? We're now doing transplantation for 50 years. So I would go a little bit further. And the problem is that, and it already has been pointed for the adult side, that we don't have that much data in literature. I mean, it's an exponential inverse curve. We have a lot of data for 5 years, and we get less and less. And when you go to 20, 30 years, it's even less. And in fact, 10 to 30 years is the span we would like to have to study very long-term outcome. And one problem that is true, and even in ELTA, is that we know a lot of patients are lost for follow-up. They are surviving to a point, and then we don't know after. There is a lot of incompleteness in the big registries that are providing the 20 and 30 years data, and it is a fact. We have to take that into account. The very long-term outcome data are also very relative indicators for our current activities. And it is true that if you look on, if you look on the curve like this one from Yunus, you can see that here there are by era a big change in outcome, which means that for the patient who have been transplanted 20 to 30 years ago, we have bad outcome because we were in the learning phase. What can we really learn from that period? Our 30 years long-term currently available data are not representing what we do today. What we do today is more on the upper curve there. You see, there is a 20% higher survival at 5 years, but we don't know, we have just to hypothesize what will be the future. So these are big limitations. We would like to know what our patients of today have as a prognosis. We would like to speak with them and tell them what is their prognosis. And in fact, we just can assess a little bit of this information. Third, what is very important for advising the patient and assessing our activity in terms of quality? Is it graft or patient? And they are related. When the patient died, the graft, even if it was healthy, is dying as well. So there is a close relation. And in fact, although the survival of the patient is our objective should be more and more graft survival, because we are losing a lot of grafts, losing then possibility of transplanting patients, and we have to target not anymore patient survival, but graft. Because if the graft is surviving, it means your patient is surviving as well. So the best indicator is the graft. But in this paper, in this presentation, I will use both patient and graft information, because at 20, 30 years, sometimes we have one paper dedicated to graft, another one to patient, and it's difficult to really match them. So I will concentrate on 10 to 30 years for what we have, and try to limit, and I will limit my speech to pediatric liver transplantation. If we cannot really learn from the outcome of patient transplanted in learning curve in 88, in the 90s, what can we take as an information from the data we have for the very long term? Trends and gradient. What do I mean by that? This is a slide made from ELTA, European Registry, 88 to 2022. And you can see that there is not very much information, except that we are not doing that good, because we arrive at 70 for the graft and 80% for the patient survival. I mean, children, we remember that. But if we look carefully, I would disassemble two periods, the early period, the first year or the first 2 years, and then after. And what after is known from this curve is that we have a steady, stable, negative steady state, which means the gradient, the slope is nearly completely fixed for 20 years. It's incredible. And this is both for patient, more importantly for me, for graft. So there is a graft loss after 2 years that seems completely predictive, very stable. We'll see this is global, so it's every indication, every type of graft, and so on. And you can see that the very first 2 years have a completely different curve, which is a very rapid slope during the first year. This is the data from UNOS, and I would like to compare that to the data I presented before, which is ELTA. And you can see that they have the same slope. And the second information is that by era, the slope did not change. The only difference between what we are doing now and 30 years ago is that we are now doing better during the first 2 years. And then after, the decrease is the same. I mean, I did not pass this through a statistical analysis because I didn't have the time, but somebody must look at that. And you will see after, I will continue to present that. UNOS in ELTA, these are the two curves. The first, on the left, you see the curve from UNOS. ELTA has similar data. The problem is that they cut the era into smaller pieces, but you can see the trends are very much the same. Now, with this slide, I tried to match the time, because you can see the time on the bottom is 0 to 30, and the other one was only 10 years. And what is striking is that in America, with their way of doing, which is a lot of full-size liver, less split, and in Europe, where we have majority of split and living in, the curve is the same. So I would say, second conclusion, it seems to be independent of the type of graft. The graft loss is the same. It's not technical anymore, because after 2 years, we can eliminate nearly all the technical complications leading to graft loss, but after, the natural slope seems to be the same in the whole world. Somebody has to look for that. I didn't. I just present what I see. I now pass to a second phase where I will present you a few data that we collected 2 years ago with Uli Bowman, and we published, and you can find this paper, the two papers. This is the complete analysis of 16,000 pediatric liver transplantation. And on the bottom, I will introduce some slides from a talk I did 2 years ago at the ELTS about split in pediatric liver transplantation and the long term. We found first that the graft half-life at the moment for the patient transplanted since 88 is 31 years after the transplantation for pediatric transplantation. That's incredible. Remember that at 20 years, the survival of adult patient is 35%. In children, the survival, the median, the graft half-life, 50%, is 31 years. That's incredible. That's enormous. Another information, and I told you that I will bring some information about the split. We know that the split has been said from the beginning, 35 years ago, that it is not a good organ, too many complications, outcome is not good. So in some countries, and especially America, is not really well developed because of limitations. It is true that on this curve, you can see that the split survival is a little bit less after 20 years, but that was really the learning curve of the split activity. So I would say that in the last 20 years, we've been doing very well because there is no difference if you do a split, a full size or other type of organs. In pediatric liver transplantation, the outcome is the same. And it is the same for the right and the left. So it means that if we do the whole, in the old time where we're doing right split into children, the outcome was exactly similar, nearly similar to the left part. You see that even the statistic on this number of patients is not significant. Can we learn more? We see that we have an equal gradient after 2 years that is independent of the era and seems to be independent of the type of graft. So I can go a little bit further in the type of graft, but before that I will show you what we have about age and disease type. Surprisingly, if you divide my graft half-life into children who are more than 12 and children who are less than 12, you find that the graft survival, the graft half-life, is 10 years smaller than the group of patients who are transplanted before the age of 12. So it's better to be transplanted earlier in life than later, even for a child. And you would say, that's because we put more full-size livers we use different type of graft. And in fact, if we want to homogenize the story, we take only the full-size liver in children less than 12 and more than 12. You have exactly the same outcome. So this is independent of the type of graft. And the information is that not only it is better, you have a better survival if you are a child compared to an adult, but you have a better survival in terms of graft. You can imagine in terms of patient, if you are less than 12 or more than 12. We put that in the paper I mentioned before, and you can go to that paper if you want to see the detail. You can see that if we go even lower, this is a curve, the green curve on the top is less than 6, then 6 to 12. They have the same curve, but then there is a gap, because if you go 12 to 18, or if you take young adult, 18 to 45, you get another slope which is well defined. I mean, the numbers here are enormous, 16,000 patients analyzed. And then you find the curve that were presented by the previous speaker, which are the adults have their own curve, and every 20 years the curve is going lower. And that's normal because they get older. What is surprising is that we find this type of difference in smaller children, and the younger, the better. And we know that today, even the younger usually are the worst because we have more technical complications. But when we go at the long term, the one who are surviving after 1 year, they have a better outcome than anybody else. Graft loss biannual, by year, is around 1% for the very small, less than 12. It's 1.8 for the younger, the teenager and the young adult, and so on. If I take now UNOS, this is a paper that was published 6 months after the paper where we found this type of lines and slopes. You can see that in this paper coming from UNOS, we found exactly the same. Less than 10 years is much better than 10 to 18 years. And the slopes are nearly the same. The UNOS paper is for patients, the other one is for grafts, so there is, of course, a little difference because some patients will be retransplanted, so you expect the patient survival a little bit better, but you can see that the slope is 0.7 patient per year versus 1 graft per year. Of course, there are 20% who may be retransplanted, but you see the slope are the same. Again, over the ocean, things are the same. So we have now a chicken-egg problem. Is it the disease type that is behind these numbers, or is it the age of transplant? So I tried to understand that, and it's difficult because it is true that if you look the slope of the survival curve for patients having different disease, pediatric patients having different disease, you find for cholestatic disease and metabolic disease that are, of course, much better, a slope which is more or less 1% per year. If you look for patient for disease like other cirrhosis, malignancies, and so on, you find 2%. And they are, again, very, very similar to the numbers I gave you before regarding age. So is it age or not? Again, coming back to UNOS, the same difference, the same similitude, in fact. Metabolic biliary atresia, 1%, acute and other disease, twice as much, around 2%. So these are the data from 88 to 2017, the ELTS study I mentioned several times. And these are the primary disease according to the recipient age. You have less than 6, 6 to 12, and 12 to 18, corresponding to the curve I showed you before. And of course, there are more patients in the less than 6, and there are a lot more cholestatic disease, which is favorable for a good outcome in that group. But now, if you look carefully, you remember we have 3 curves. The 2 first, this one and this one, have a profile which is around 1% loss. And this other one has 1.8. So now, it's difficult to, I did not have the time to do the statistical analysis of this, and I think we have to go into something complex to understand better. But what I can see, just simply like that, is that the 2 first columns, this one and this one, they get the same trend, but they have a big difference in terms of disease. I mean, they are really a lot more cholestatic in this one than on the second, but they have the same outcome. And if I go with The two other ones, they have a similar profile of a disease, and they are completely different in outcome. So I don't know who will do that study, and I suppose there will be somebody interested to do it. But I mean, I would guess this is more the age at transplant than the type of disease, the primary disease, that is important. So the earlier you transplant, the better. And this is going opposite to what we have been told in the past. In the past, there were even papers saying you should transplant patients later, children later. Not sure anymore. And this is the split data I found 2 years ago, and that are even more concerning or surprising. I mean, these are all patients, children, who get a split liver graft when they were young. Then I started the curve when they are 18. So the point of the departure point for this survival is patient is surviving with a split graft until 18, okay? And then I see how they go. You see that the children who are very young, with their split transplanted 12 to 18 years ago, are doing better. They are surviving better after 18 if they have been reaching 18. And again, the slopes are the same, more or less. 1% graft loss, you see that there is nearly nothing for the patient who is less than 6 at the time of a split transplant. Starting from 100% is 96, so loss of 4% in 10 years, which is 0.5, a little bit more or less. Okay? So these are factors that show that the earlier the better. Children who are transplanted very young, if they succeed, if the transplant succeeds, of course, you have to go through a few things. But I mean, their prognosis is very good at the very, very long term. Somebody has to study that. I did not. Conclusion, long-term outcome after pediatric liver transplantation is very satisfactory, although we may have to improve it better. Negative steady-state gradient of 1% graft loss per year after the second year. The survival benefit of children is much superior, but we know already that compared to adults. Can we do even better? So you see that this curve is characterized by two areas. The first 2 years, a drop of 20%. These are data from 20 years ago. And then a slope which is stable. And of course, we should try to move the curve up by first. We stop losing graft and patient during the first year. Everybody knows that, and it is true. So that would lift the curve by 20% up the whole way, up to 30, 50 years after transplantation. But we could also try to lift the curve and the slope from 1% to 0.5 or less. And my feeling is that if you get your transplant much better, a better graft without complication, you may impact on the slope. The slope may represent immune problems, but it may also represent late technical complication, late complication related to ischemia, biliary problems, and so on. So we can act as surgeon on that as well. And that already has been pointed 20 years ago. I mean, we know that the most important factor for decreasing the outcome after pediatric liver transplantation is what happened during the first 6 months, I would say even during the first 2 months, and that is related to the choice of the donor, the type of graft, and the technical aspect. This is a slide from recent years with the graft loss, and you can see that very quickly, over 5 years, we have that much of graft loss, but 87% of the whole graft loss during 5 years happens during the first month, in the last decade. And the same, over the 5 years, we have a lot of patient loss. 72% of the patients dying within 5 years after transplant died during the first month, not even 6 months, first month. And this touches all types of graft. You can see that on the bottom, the rate of failure by vascular problems or dysfunction is stable all the way through, even in living. And that, I don't know why, but that's surprising. I mean, that you can lose so many grafts after the transplant is surprising. After a living transplant is surprising. So this is my experience in Italy, 17 years of activity since 2008. So 275 first isolated pediatric liver transplantation. There was only one patient retransplanted, and he was not retransplanted in our center. 60% were less than 12 kilo, 60% were biliary atresia, a lot of living donor, half of them, and only 12% of the transplant done with full size. A little bit of 7% with RBO incompatible. I passed this one. It is possible. If you don't lose graft at the very beginning, the survival of the graft at 1 year in this case is 99%. Most of the patients died from recurrent disease. There was one primary non-function and there was one retransplantation at the long term. 99% at graft survival at 1 year, 96% at 15 years. And you can see that the curve is now flat. There is no loss. There will be loss, of course, after 15 years. There will be some. But the curve from 1% slope is now close to 0. It will never be 0. I know that I just have to wait for one dying. It will be less. But, I mean, it is closer. So the last part, which is how can we move the slope from 1% to less than 1%, possibly is not only immune. Of course, there are children. Many of them are living. And we use a very low immunosuppression, so we don't have PTLD or very little, 1%. And it is possible to arrive to that. I thank you for your attention.